My name is Dr. Phil Janicak. I'm a professor of psychiatry at Rush University in Chicago and oversee the psychiatric clinical research program there. And today we're going to talk a little bit about therapeutic neuromodulation. The prototypic example, of course, is electroconvulsive therapy, which has been available for over 7 decades and still remains the gold standard for some of the most severely depressed patients that we encounter in our clinical practices. However, because of dissatisfaction with some aspects associated with ECT, as well as lack of response to many other standard approaches such as medications and psychotherapy, other forms of therapeutic neuromodulation are re-emerging or coming to the fore as new approaches. And the idea of therapeutic neuromodulation is that the brain is an electrochemical organ, and we can modulate it chemically with pharmacology, or we can modulate it by a variety of approaches that alter the neurocircuitry that we think is implicated in the symptoms associated with various psychiatric disorders. And the focus primarily has been on depression at this juncture. So I mentioned ECT, and while it's been available, it certainly does come with some downsides. The cost of the treatment, the stigma that's often associated with it, the very high relapse rates that occur even after acute response are all mitigating factors that oftentimes do not allow patients to take advantage of this treatment. Another important one is that only about 8% of psychiatrists actually provide electroconvulsive therapy in the United States, and so access to this treatment can be quite limited in certain areas. So another approach that has emerged recently is transcranial magnetic stimulation, or TMS. And this particular approach is not what I would consider equivalent to ECT, but rather I think about it in terms of patients who in the past, when TMS was not available, but couldn't benefit or couldn't tolerate antidepressant medications, augmentation strategies, psychotherapy, or various combinations, didn't have any other options. And even though they might not meet the clear criteria for candidates for ECT, still had to go forward with electroconvulsive therapy. It's possible that some of those patients could benefit from TMS as an alternative. And this is an approach that allows for the delivery of very intense magnetic fields over typically the left dorsolateral prefrontal cortex. And these fields go on and off in a very rapid fashion, and in so doing they stimulate the surface of the cortex below where the coil is placed. And secondary to the stimulation, we see neuronal depolarization, increase in metabolism, increase in blood flow in that area. But perhaps more importantly, through transsynaptic connections, we also see alteration of the deeper neurocircuits that are frequently implicated in the symptoms of depression. TMS has been available clinically for about 3.5 years. There are approximately 400 centers in the United States at this juncture. And as we go forward, we're learning a lot more about the treatment strategy, its advantages and its disadvantages. Clearly, we would like to get the TMS to the point where we optimize its application, and there are a variety of different strategies that are being considered at this time. One of the major advantages of transcranial magnetic stimulation is the lack of systemic effects that we often see with medication. So things like sexual dysfunction, weight gain, anticholinergic effects are virtually absent with TMS. However, with this particular approach, there is a potential for an inadvertent seizure. So unlike ECT, where we are attempting to induce seizures for therapeutic benefits, we're actually trying to avoid them with transcranial magnetic stimulation. But if one should occur, obviously, it's under unmodified conditions and has to be managed. The good news about that is that the incidence of seizure with TMS is about the same or lower than we see with most of the antidepressant medications that we prescribe for patients. Yet another alternative in the general context of therapeutic neuromodulation is vagus nerve stimulation. Vagus nerve stimulation has been available since the late 1990s for treatment-resistant epilepsy, and in the mid-2000s became available as a treatment for resistant depression. This is a more invasive procedure, however. We have to proceed with the surgical implantation. It's a cardiac pacemaker-like battery device that's placed under the left subclavicle area. A wire is run subcutaneously up to the left vagus nerve. Electrodes are attached, and then after the healing process occurs post-surgical, we can adjust various parameters with a computerized wand to optimize the stimulations to the left vagus nerve. And we use the left vagus nerve because most of the fibers are going back into the central nervous system as opposed to out into the periphery, the heart or the gastrointestinal tract, as is with the right vagus nerve. And so we're trying to stimulate some of those same circuits that we're getting at indirectly with transcranial magnetic stimulation in a more direct fashion through the fibers associated with the vagus nerve. The potential downsides associated with vagus nerve are the expense associated with it and, of course, the complications that could ensue from the surgical procedure. Unfortunately, at this juncture, third-party payers, Medicare and Medicaid in particular, do not reimburse for it, and so it's very difficult to get the procedure accomplished. It's about a $25,000 cost for the initial implantation and additional cost for adjustments that are needed afterwards. And so at this juncture, unfortunately, vagus nerve stimulation is not available for most patients in the United States, but we'll have to wait and see if that changes over time. The last area that I want to talk about is another form of therapeutic neuromodulation referred to as deep brain stimulation, or DBS. And you could think of this approach as a kinder, gentler form of psychosurgery. The procedures require the implantation of two cardiac pacemaker battery-like devices, usually under the right and left subclavicle areas, and then wires are run subcutaneously back behind the ears up to the top of the head. Burr holes are drilled, and then the wires are put deep into the areas that we think are critical junctures for the control of the neurocircuits that we were looking at and talking about a little bit earlier. At the end of these wires are a series of electrodes which can be adjusted in terms of distance from each other and the way the stimulations are provided, whether they're inhibitory, whether they're excitatory, or whether they vary back and forth, can depend on which protocol one is following. Under those circumstances, as some of you may know, deep brain stimulation was recently approved under the humanitarian program for the FDA for very severe treatment-resistant obsessive compulsive disorder. But there's also a growing database indicating that it may also be helpful for some of the most severe and refractory depressions that we encounter in clinical practice, and that includes both unipolar major depression as well as bipolar depression. So those are some of the areas that I wanted to touch on in terms of therapeutic neuromodulation, and hope it gives you a brief overview of where we're moving at this time. Thank you.